Hi everyone, this is Sirina Keesara, and today I'll be talking to you about the progress of my work on the barriers to the use of postpartum contraception in Nairobi, Kenya. So you're probably wondering who I am, so this is me in case we don't get to talk later on Skype. And I've been working at Jacaranda Health for the last year in Nairobi. And that's why I haven't been around at any of the classes or fellowship events. But this is kind of the stuff that I've been developing for Jacaranda Health, the family planning program, patient education materials, but more about that later. First, I want to thank my mentors in San Francisco and Nairobi. Number one is Cynthia Harper, who has been so instrumental and so tremendously generous with her time in helping me develop a protocol before I took designing clinical research, which I'm really grateful for. She's my mentor for this fellowship now as well. Sorry, that's a crow. And then number two, Chris Stewart, who has been a wonderful liaison between me and UCSF while I've been here in Kenya. Number three, Dr. Christina Machari, who is my local mentor and helping me adapt the protocols here and helping me submit to the Kenyan local ethical board. And number four, Moses Owino, who is the director, the medical officer at the facility that I'll be working in. And of course, Nick Pearson, who is the founder of Jacaranda Health, lives in San Francisco, works in Kenya, comes back and forth all the time, and without whom I wouldn't be able to get this wonderful experience. So thank you. So I wanted to talk a little bit about the development of my question over the last year working at Jacaranda Maternity. Their first services that they developed were the delivery services and antenatal, and then afterwards postnatal care. But my goal over the last year was to design their family planning program focusing on postpartum family planning. And why postpartum family planning? Because number one, the rate of uptake at 6 weeks, which is the recommended time for women to initiate contraceptive use after delivery, is at 15%, which is really, really low. There's a very high unmet need within this time period. In the demographic survey done in 2003, there was documented 68% of women in their first postpartum year having an unmet need, which is defined by women who do not want to get pregnant but are not using contraception. And lastly, it's an easy target for us because it's tied into our postpartum visits and care, which it should be. So how I've been doing that, I've been developing protocols, new documentation, visual aids, decision-making tools, nurse training, auxiliary healthcare provider training, patient education materials, and general integration of the family planning care throughout antenatal and postnatal. And I've been using the best practices and evidence-based recommendations from WHO and Population Council and a lot of the innovations that have been developed around postpartum care. But then when I looked at the rate of family planning uptake at 6 weeks of our patients who are delivering with us, I found 15%, which, if you remember a few slides ago, is about the same rate as Kenya's. So I was wondering, after using all these best practices, quote unquote, what was going on. So we did a little bit of an investigation. I just want to let you know these are completely informal results that helped me develop my question, but are internal Jacaranda research. So we found that women did want to use contraception and knew that they needed to immediately after delivery, and wanted to get information before delivery to prepare themselves for that. But there were a few barriers to use, one of them being not knowing when they were going to return to fertility. Many of them thought that the return to menses was the indicator of return to fertility, which would make sense, but you can actually ovulate, well, you do ovulate 2 weeks before your first menses, so that puts a lot of women at risk. And then secondly, they experience a lot of partner disapproval, and I really like this quote. In my case, they will not allow, they will not attempt, I would rather stay in the woods, which was referring to her husband and her family, and so she didn't want to tell anybody that she was going to be using contraception. So that led me to my question, what actually prevents women from using contraception within the recommended time frame if they initially have a high motivation to use it early? So what is the recommended time frame? Biology side note. We want women to use contraception before they ovulate for the first time so they're protected. So going through the hormones after delivery, when the placenta is delivered, there's a huge drop in progesterone and estrogen, and 7 days later, prolactin falls, and then stops inhibiting GnRH from its normal pulsatility, which, when it resumes, starts to instigate progesterone and estrogen, which develops a follicle and also leads to a positive feedback cycle of LH from the pituitary, which causes the first ovulation in non-breastfeeding women at 4 weeks. In breastfeeding women, nipples suckling promotes prolactin secretion, which inhibits the pituitary from releasing LH, which doesn't let follicle develop and ovulate. So the recommended time frame is between 4 and 6 weeks, depending on whether you're breastfeeding or not. And if you're exclusively breastfeeding, you can use that as a primary form of contraception for up to 6 months. So then what is actually stopping women from using family planning in this time frame according to the literature? So there's lots of research, cross-sectional studies done about the barriers. There's financial barriers, false medical requirements, poor quality care, provider bias, and tons of misinformation about myths and all sorts of rumors about side effects. The three main barriers that I found in the literature in East Africa are: number one, partner disapproval, lack of information about when to return to fertility, and then misinformation again about what it's actually going to do to your body after delivery and to your baby and all those kind of things. I also found this in my field research or field work, just informally attending governmental family planning outreaches and talking to women there. From this background research and my field work, I wanted to see what the actual barriers to postpartum contraceptive use were in our area and for our clients. So I was thinking of doing this cross-sectional study about barriers in our area, and then I talked to the African Population Health and Research Center, and they suggested that instead of doing just a cross-sectional study, we also look at a longitudinal view following women over the course of 6 months to see what actually happens to them and what actually they're preventing them from using contraceptives or motivating them to use contraceptives over their first 6 months after delivery. So my research objectives, number one, is to do a general survey, that cross-sectional look at barriers, and number two, to understand how the discourse changes and how the barriers influence the postpartum women differentially over the course of 6 months to assess what is motivating them or dissuading them from actually going to the clinic and using contraceptives. So my study design is going to be a qualitative prospective cohort. I'll be following 30 women over 6 months with 3 interviews, one at 6 weeks or a little before 6 weeks, one at 3 months, and one at 6 months, to assess generally their postpartum wellness, and then also incorporate questions about contraception, because we don't want to bias them if they're continually being asked questions about their contraceptive use over 6 months. The study population will be low-income women living in urban Nairobi. Study location will be Mathare North Health Center, which is kind of an analogous institution to Jacaranda Health. It has all the same facilities, but it's governmental, and there's a larger patient flow, so recruitment will be a lot easier. And my outcomes will be qualitative themes. So now that brings me to this. I'm kind of stalled at the ethical approval here in Kenya. I have approval at UCSF for a while now, but they say that I'm in the last stages of their approval process here, and so hopefully they'll get it to me before I have to leave, or with enough time so I can do the 6 months of data collection before I have to leave. But so in the meantime, I've been doing a lot of literature reviews about postpartum contraception and best practices, and also I've been working with Jacaranda Health on a programmatic approach to one of the barriers that I found in our preliminary investigation, partner disapproval, on this questionnaire, which is meant to be a way to help couples decide together about which is the best form to use for them. So it's to be given to the woman during antenatal care or immediately after discharge, if her partner's not there, to take home to him to bring up the topic of family planning, because that was one of the main issues in spousal communication that we found. Both men and women wanted to talk about family planning but didn't know how to bring it up. So this is supposed to kind of ease that process and then give them some information about family planning. So this was actually the topic of my DCR protocol, and which was really fun to develop a protocol to actually assess whether this tool would actually work or intervention would actually work. The question is, does a paper-based decision-making tool about postpartum family planning given to women during pregnancy or before 6 weeks postpartum increase partner communication about postpartum family planning? So this will be, I designed it as a randomized controlled trial, same study population, low-income women in Nairobi. The sample size that I calculated was 139 per arm, which seems a little bit large and might need to be adjusted according to feasibility. The study location will be in Jacaranda Health, and then the outcomes, which I thought were the most fun to come up with. Number one, I decided on the self-efficacy questionnaire, ability to use family planning, or self-perceived ability to use family planning with a partner. This questionnaire was developed in a larger study in Malawi, just published last year, about spousal communication around family planning. So hopefully I can get those questions because it's a validated tool. And then number two, the second outcome, women's perception of partner approval, which I found in an observational study about partner communication in Kenya, done about 10 years ago. This specific indicator, this whether women perceived that their partner approved of family planning or not, was highly correlated with high use of contraception. So I'm hoping that my intervention will help couples bring up the topic and then help women realize that their partner is not opposed to it if she was previously thinking that he was, because they just weren't discussing it. Because that was one of the major findings, that there's a lot of discordant attitudes, like the woman thinks he's against it but he's not. And anyway, so I want to look at those outcomes. I'll submit my protocol to see what the reviewers think, and yeah, the whole study design is thanks to the course, which I'm very grateful for the fellowship sponsoring. Anyway, thank you very much for listening, and hopefully I'll be there in a few minutes to discuss or answer any questions. Thank you.